Welcome to Muslims and Mental Health with Sister Heather, a groundbreaking program looking at mental health issues through the biopsychosocial spiritual paradigm.
Welcome to another episode of Muslims and Mental Health. Today we are starting our part 2 of our series on the psychology of aging. Particularly today we're going to be looking at the psychopathology of aging. I just want to though open with a few facts. One, that mental illness is not a manifestation of aging. In fact, approximately 88% of people over the age of 65 do not suffer from mental disorders. Excluding cognitive impairment, this means this group has the lowest prevalence of mental disorder by any age group. Today I'll be joined again by Dr. Scaglione. Dr. Cris Scaglione is a professor at the Chicago School of Professional Psychology of Southern California. She is trained in clinical psychology with a specialization in neuropsychology. She has worked with older adults for the past 20 plus years. So please join me again in welcoming Dr. Cris Scaglione. Welcome back to our show.
Thank you.
So today we're going to switch gears a little bit and talk about the psychopathology of aging. And I want to ask you first, for our audience, what is psychopathology?
Okay. The technical term is psychopathology. Pathology means illness. Psychopathology means mental illness. If you think of anybody that has, say, depression or high levels of anxiety, that would be psychopathology. In the older adult population, probably the highest psychopathology is actually cognitive disorders, dementias, etc., as well as fairly high incidences, unfortunately, incidence of depression. Mm-hmm. This can be reactive or part of a long-standing sort of downward spiraling in someone's development. But I'm glad you pointed out, because this is a frequent misconception, I'm glad you pointed out that most older adults do not have a mental illness. Mm-hmm. We often think of older adults as being somehow, again, frail, impaired, not functioning well, and that's not necessarily the case. So I'm glad you opened with that statistic.
Yeah, I think that is something that's just assumed, right?
Yeah.
What are chronic and acute stressors, and how is that relevant to aging?
Oh, okay. Well, life is, if you're going to be a bit of a pessimist, life is one stressor after another, right? It's one, you're always coping with something. Mm-hmm. So, however, a stressor would be something that's a little bit beyond the normal day-to-day sorts of adjustments that we have to make. A chronic stressor is something that is long-term. Many people have, especially older adults, have chronic stressors that have to do with, maybe not being able to drive, or a long-standing health issue, the onset of some chronic illness such as diabetes or heart disease, having to deal with cancer or recurrent cancers. These are the kinds of things that would be considered chronic stressors. Distress in the family. Maybe that's been going on for decades. That would be a chronic stressor. An acute stressor is short-term, or at least it could turn into a chronic stressor, but for the person at that point in their life, it's new. Mm-hmm. It might be hearing for the first time a negative diagnosis. It could be severe illness or possibly death of a family member, especially a spouse. Those are considered to be over-the-top kinds of problems or stressors to have to deal with. And again, acute just means it's short-term or it's been recent in the person's life.
So when we look at the aging process and in terms of acute and chronic stressors, mm-hmm. are they more impacting, the same as another age group? I mean,
that's a good point. I think by the time you've gotten past 65, you've had your share of chronic and acute stressors. And they are potentially more impactful if the older person is becoming more frail or has the onset of cognitive impairment. In some ways, though, many older people are better equipped to deal with stressors because they've been there and done that. Mm-hmm. So it depends on the person's life history, health status, that sort of thing. Mm-hmm. Its relation to psychopathology is, of course, that any stressor can result in an anxiety disorder or a stress disorder or a depression, that sort of thing.
So just to circle back for a second, when you talk about one's ability to deal with that acute and chronic stress, is that also related to personality?
It certainly is, yes. A personality style, whether you tend to be more optimistic versus pessimistic, where you tend to get anxious about things, or you've learned over time to just kind of let it go and go for the ride because you know it's going to end somewhere, sometime rather. Younger people sometimes have more catastrophic reactions to stress because they haven't had that experience before, and they haven't understood that, yeah, this is not fun now, but 2 weeks from now it'll be okay.
And so what are mediators to stress? Like, for example, coping strategies, social involvement?
Just as in any age group, mediators of stress include, as you said, coping strategies. How did you grow up learning how to deal with stress? What do you do? Do you deal with it head on? Do you avoid it? Do you drink? Do you get abusive? Do you cover your head and ignore it? So how you've decided, and there's some predisposing factors, of course, but how you've decided or learned how to deal with stress is hugely important. Whether or not you have social support, family support is hugely important. It's one of the best predictors of any kind of long-term outcome for an older adult, for somebody in rehab. And I say rehab, I'm thinking more physical rehab, but it could be chemical rehab as well, chemical dependency rehab. One sense over time of what we call self-efficacy, which is a sense of confidence in your ability to master what comes your way. That usually comes with experience. And again, I can't overemphasize social support. And I think we talked on the last segment about, again, that balance between affiliation and autonomy, social connectedness and independence. If that balance is in good shape, you have a lot of resources available to you to handle a stressor.
I know that you mentioned coping strategies, but what are some of the ways to cope with psychosocial changes and developmental crisis?
Right. One of the things that people, I think, underestimate in aging is the number of developmental challenges that are faced potentially. It is actually a period of continuing growth and development, almost at the pace of, not quite, of course, at the pace of childhood and adolescence, but young adulthood, middle adulthood, things, the developmental challenges are fewer and farther between. As we age, there's a number of potential developmental challenges that occur with changing role expectations, retirement, or being laid off, or being disabled physically, dealing with major changes in your family. Your family's now gone away. Now what do you do with your life? There's many, many things that an older adult has to adjust to. Sometimes, if one after the other, there's a lot of changes that they might be exposed to. So the way to cope with that is to understand and accept that, yes, in this later phase of my life, going to be a lot of things I have to deal with. And also accept the fact that many of these things are going to be sudden and unexpected, such as loss, health changes in myself, in my family, in my friends. As you get older, your friends start dying off. And to, as gracefully as possible, accept that these are going to happen. So some of it is an attitude. Ideally, you've also done what Carstensen has suggested that we do, and that is we have been choosing over time, choosing the relationships and the activities that are the most rewarding, that are the most positive. That will help a lot to buffer how changes and stressors affect one's life, oneself. Having positive interpersonal relationships, not negative ones, not authoritarian or conflictual relationships is really, really important. And again, that one sense of autonomy and independence and possibly, again, self-efficacy, those are going to help buffer how stressors affect you.
And of course, there's no way to shield yourself from everything, right? Because
Nope.
I had an elderly person recently describe to me a situation where around finances, right?
Yeah.
And the way our society views the elderly and healthcare and finances, and they were experiencing a situation whereby their loved one was ill, but because of the way the insurance was structured, they couldn't get into even hospice care until a certain day.
Yeah.
And so just that you would just not be expecting it.
No.
You would think that people would want to care for others just naturally, but then it doesn't exactly happen that way.
No.
Yeah.
Right. And
So there's unexpected things as well.
unexpected,
that are out of your control.
highly stressful.
Like,
yeah. And levels of loss that you cannot fathom usually. Hopefully not as a younger person.
Yeah. And so, given that, we sometimes see, as you mentioned in the previous episode, and we're going to discuss a little bit more now, the idea of depression. And so, what would be the prevalence of depression in aging, and what are some of the risk factors for it? And does it look differently than other age groups or other parts of our development?
Okay, that's a multi-part question. Hopefully, I'll remember all of them.
If you don't,
if
I'll
not,
come back
catch
to
me. The various there's a wide range in the studies that talk about the prevalence of depression in older adults. So I chose to go with the CDC, the Center for Disease Control, which has some pretty good data. Generally, about 20% of adults 55 and older have some kind of mental health disorder, which includes depression, anxiety, and or cognitive decline. So it's hard to separate exactly what levels of depression are. I've seen studies that say as high as 25% of older adults are depressed. That's extremely high. I'm not sure what their sampling was. It might have been a sample of, I don't think it was a community sample, for instance. I think it was samples in, say, convalescent homes, which are definitely going to have higher levels of depression. But that is in about what the normal population, the incidence of mental illness is. But just getting back to mental illness in general.
I want to go back there for a second, though, and unpack something that you said a little bit more around the percentage around why it might be called depression, and that could be masked by cognitive issues.
Yes.
So what maybe looked like depression is not actually depression, but because of the cognitive issue, right?
And we can go there now if you want, but there's definitely we can have a longer conversation about how changes in cognition look like and maybe can be or are complicated by depression.
Okay, so we'll table that for now.
Oh, no.
And just go back to what are the risk factors for depression?
The risk factors for depression in older adults are very similar to it, and in fact, you asked what it looked like. So let's actually, if you don't mind, what's it look like? It looks just like it does in younger adults.
Okay.
My experience with older adults, though, maybe some slight differences, and that is older adults can maybe be a little more anxious along with their depression, and their depressed mood may kind of flip more quickly back and forth between anxiety and depression. And the depression can be quite severe and disabling, or it can be more kind of mild to moderate. And a lot of that is in reaction to continued loss and continued trauma and stress. But generally, if a middle-aged person and a young person and an older person who were depressed walked into the room, clinically they would look pretty much identical. What we have to be careful of is testing. The use of psychology depends a lot to firm up a diagnosis on certain types of testing. So self-report questionnaires or checklists that a clinician might use to say they have this, this, and this, therefore these symptoms suggest that diagnosis. In older adults, we have to be very careful of depression inventories because a lot of the symptoms of depression could simply be normal, life. So, or the kinds of things that are fairly typical of an older population, such as changes in sleep patterns, changes in appetite, changes in
loss.
Exactly, or also changes in movement. Movement tends to be slower in adults who are older, as well as in adults who are depressed. So we have to be very careful not to look at those factors as being in equal importance to, say, mood and attitude factors.
And it occurs to me from some of the things that you shared previously that would an elderly person be less likely, so whereas a younger person may be more open about reporting their feelings or that they're depressed or feeling depressed, an older person might think, well, I can manage this,
They might, yeah.
And not be as forthcoming, be thinking that, they have the ability to manage it.
That sometimes occurs. Also, sometimes some people are not even aware that they're depressed. It's just been this kind of slowly downward spiraling set of events that the person thinks is normal, or they don't really notice it because it's been happening over a decade.
Right.
And they don't realize they're depressed until other people start to notice. I have noticed, though, one of the things I like about working with older adults, for the most part, there's always variation, but they tend to be more straightforward about things. They tend to not be as interested in protecting their self-image as younger people can. Again, there's exceptions to that, but that's one of the things I like about them.
But I guess also one of the dangers would be, as you were talking about people noticing over time,
Right.
If there aren't people to notice.
Exactly. And that's why, especially older adults that don't have a lot of contact with people, hopefully there's some kind of community agency that's checking up on them and can notice these kinds of subtle declines that culminate over the years.
Yeah, it really highlights the importance of communal responsibility.
Yes.
Okay, and so what are some of the conditions that may mask depression or cause depression? We talked a little bit about cognitive changes, but...
So, and when we're talking about causes, we'll also talk about risk factors. They're almost the same, in fact. Well, as with anything in older age, if you've been kind of depressed or anxious or, have had some prior mental illness, that's always going to affect whether or not you get another mental illness or depression as an older adult. But also trauma and stress and loss, which can be in a person's life quite abundant as they age. Those are definitely risk factors. Unfortunately, also some cognitive decline and or incipient dementia is a huge risk factor for depression, as are some cardiovascular issues. They can cause both depression and dementia, and sometimes it's hard to tell them apart.
And could you define incipient dementia for our audience?
Sure. Well, dementia, first of all, requires two things, actually: memory loss plus other cognitive loss. It's what we normally, a lot of people say they have Alzheimer's, when in fact they might have some other type of dementia, but Alzheimer's would be the most commonly known example of a type of dementia. So dementia is a continually declining cognitive brain impairment, which shows up as changes in thinking, memories, and eventually emotion. Incipient would be just the early stages, the early phases of a dementia. They can look it can look very much like a depression. Some dementias cause depression, or the brain changes and the chemical changes that go with the cognitive problem can directly cause a depression. Or in the early stages of a cognitive decline, a dementia, people can be very upset by this and be very discouraged. So they have what we call a reactive depression. It's in reaction to this terrible news and noticing loss of function. Later stages of dementia, there's less reactive depression because there's less awareness, but there might still be what we would call a chemical or neurological depression that's very resistant to medication, unfortunately, because the the underlying brain systems that would normally be available are not. And so you can pump all the medication you want in there, and it's not going to respond well.
So they're kind of offline. Sort of.
Okay. Yes. Yes.
Okay. Well, I have a few more questions I'd like to ask you about this topic, but I need to take a short break for our sponsors, and we'll be right back.
Hi, welcome to Adelante. This is Adelante Recovery, and my name is Yvette Kuglin, and I'm part of the staff.
Adelante Recovery Center has helped people in dual diagnosis for 5 years. We accept most PPO insurances and provide luxury accommodations and 24-hour support. To speak with an admissions counselor, call 1-888-242-4450.
A lot of time we don't even know what's wrong with us, and sometimes we need to get away to figure that out. So if you want to go for a little retreat out in Corona Del Mar, which is a confidential location, we're here to help. So we're only a phone call away. Thank you.
Welcome back to Muslims and Mental Health. Again, we are discussing today the psychology of aging, in particular psychopathology in aging, and the second part of our 3-part series with Dr. Scaglione. We're going to continue on right now, and I want to ask Dr. Scaglione if we could empower our viewers a little bit, their caretakers and their loved ones who may be going with them on doctor's visits. What kind of exams or inventories should they be looking for from the doctor to get a good health assessment of distinguishing between what is depression versus a cognitive issue, something they could ask about?
Okay. First of all, I would recommend people go to either a physician, a psychiatrist, or a neurologist or neuropsychologist that has experience with older adults. Mm-hmm. One thing that comes to mind as you say this also is that because medication as well as physical illness can look like either depression or cognitive changes, that would be a good place to start. Mm-hmm. To get a good, what we would call a workup for either depression or dementia, you should look at physical illnesses. One of the things that's really, really important to watch for, and it seems so minor, is a urinary tract infection. Some people have come in to be evaluated that I've seen, and they look really confused and really out of it. And we find out they have a urinary tract infection. Right. I stop the evaluation immediately. I say, go to your doctor, bring her back in 2 weeks. And she's
because if it goes on too long, you can see cognitive issues.
Yeah. Oddly enough, people can actually get septic even from a urinary tract infection that goes on. But just a mild fever and the fact that, see, as we get older, we have less water in our system, and our kidney and liver functioning slows down. Mm-hmm. So if you have a bladder infection, you're actually building up a lot of toxins in your blood rather quickly. You also have a low-grade fever that affects the person's thinking a great deal. So simple things like that, it's an easy diagnosis. Medication, get a complete medication review. Sometimes people are over-medicated, or they're taking medications that interact with each other in such ways that they're being like overly sedated, or one drug is counteracting the cardiac meds, and so their cardiac function is not working well, and they're not getting oxygenated enough. So a good physical exam, medication review, and then in a conversation or in the interview with the client and their family, talk about various symptoms of depression, especially mood-related sorts of things, remarks like, oh, this will be my last visit. Those are like major red flags. And frequently the psychologists, psychiatrists, and other mental and medical health professionals will use tests, or like essentially symptom checklists for depression that are not appropriate for older adults. I think I mentioned earlier that a lot of physical symptoms that are relatively common to older adults can look like depression, but it's not. It would be if it was a younger adult. So there's particular. I would suggest probably what we call a mental status exam, which is a short review of cognitive functioning. That is memory, attention, basic thinking processes, plus at least a depression screening that is not the commonly used Beck Depression Inventory, but something like a geriatric depression scale or other depression scales that do not emphasize so much the physical aspects. Those are some things I can think of offhand.
And so the doctor should know about these things.
They should, and if they don't, perhaps
that's
the family
a sign
member
maybe to go
somewhere else. It's actually hard to find, despite the fact that our country is aging rapidly. In other words, the baby boom generation is now old. There are very few people that get geriatric training. Probably 10% of physicians have a specific training in treating older adults. And you really, if you can find a specialist, I don't know of any offhand, or I'd plug them. If you can find somebody like that, they're golden.
Okay, so to move a little bit away from that, but in the similar vein, how does someone diagnose depression?
Well, sort of as I mentioned, you're going to look at changes in mood, in interests, in activity level, self-care. You want to take them to a physician, a psychiatrist, a neurologist, a professional, and there will be an interview with the person, ideally also with at least one other member of the family, perhaps some testing. That would be the ideal approach.
And so I want to move on from that a little bit. If we did actually record earlier a previous episode on just depression. So for our viewers who are interested in that, you can go back and check that out with Dr. Joseph Furterman. But just to move on from that a little bit, what's the relationship between depression and Parkinson's and depression and Alzheimer's? Okay.
I'm going to maybe move up one layer from that. In general, both Parkinson's disease and Alzheimer's disease are both brain disorders. They both go with a dementia. Parkinson's disease is first and foremost a motor dysfunction of the dopamine system and the basal ganglia, but it almost always goes with cognitive changes and depression. But other dementias and other brain disorders also frequently go with depression. When I was in graduate school in the 80s, we thought that by now we would have black and white distinction between dementia and depression in older adults. If anything, it's gotten more confusing. As it turns out, depression may presage dementia. Dementia may presage depression.
Interesting.
Depression and dementia may come together in the same disorder. The brain systems that deteriorate in a dementia can cause depression. As I mentioned earlier, in the early, more aware stages of dementia, someone can become really depressed because they know what's coming. So it's actually quite complicated, quite complex. You cannot also tell just by interviewing someone. I would recommend that if there is a confusion or concern about a distinction between dementia and depression, that you actually get a neuropsychological evaluation. There are people who look really, really depressed when in fact they're quite demented. There are people who look quite demented when in fact they're really depressed. And it's hard to tell the difference without a lot of really fine-tuned testing, interviewing, and pulling a lot of sources of information together. So specifically back to Parkinson's, as the Parkinson's, and actually with the Alzheimer's as well, truly as the disease progresses, the brain systems and the neurotransmitter systems and some of the brain regions that are involved with mood and the regulation of mood and emotion deteriorate, and that can cause significant mood changes. The person can frequently have bouts of irritability as well as depression, and sometimes the irritability is depression. It's actually a fairly complicated picture, because what's happening is that there's a progressive disease of the brain, and the brain is the organ which allows us to feel, express, and regulate our emotions. And almost inevitably, some level of depression will occur, certainly in Parkinson's, certainly in Alzheimer's, and in most cognitive diseases. So we were hoping to have it all straightened out by now, but it's complex.
And so, what is vascular depression?
Well, that's almost like saying, what is vascular dementia? Okay, they do tend to go together. So vascular refers to, of course, your veins. So it refers to your circulatory system, your heart and the arteries and veins that go with all that. As we age, there are potentially normal changes in blood flow, particularly to frontal regions, also to what we call the parietal lobe, the big part of our head back here, that affect cognition in ways that are relatively normal, the kinds of things I talked about in the first of the series. But there's other, if this goes further, and there can be further deterioration of the blood flow to the brain. The brain is very hungry for oxygen. It uses about 20% of our oxygen, at least when we're thinking. The other 80% goes to the rest of the body, but most of it, actually, when we're really active, sometimes that's almost reversed. It's a very high user of sugar and oxygen, which come in the blood. If these areas are continued to be deprived of the life-giving blood and oxygen and sugars, then one of two things can happen, frequently both. You can have a cognitive decline, and or you can have a depression. And right now the trend seems to be that the idea of a vascular depression is pretty popular, but it almost always goes with a decline in executive skills functioning. And that is lack of circulation to the frontal lobes. And it's very hard to tell, really, if it's a dementia or a depression or if it's both. That gets
So it
to
sounds
that.
Again like one of those complex situations where it's not really clear.
Right. Now, it's always a good bet, though, to try to treat the person as if they had a depression. Give them the sorts of things that we would normally do for someone with depression. That would be therapy, psychotherapy, particularly cognitive behavioral therapy has been shown to be very effective with older adults with depression, but also something that's called interpersonal therapy, which is essentially a cognitive behavioral therapy that really focuses on developing or improving a particular relationship. That, in combination with medication, can target the depression, and it also, if it works, it improves both the depression and the thinking. So it never hurts to treat it as if it was a depression.
And what is pseudodementia?
Okay, we have been talking so far as if a dementia can look like a depression, but the opposite is also true. A depression can look like a dementia. Somebody who is extremely depressed, but they are in fact demented. And this is because depression and dementia can affect your mood, your ability to take care of yourself, self-care, hygiene, the care that you put into cleaning up your house or making your own meals. They're both affected by those things, and so they look very similar. The person with very flat, sad-looking face could be depressed or have a dementia. So pseudo-dementia is, it's called pseudo-dementia because it's not really a dementia. It's pseudo. It looks like a dementia. And it's in someone who is quite depressed, but looks like they have a lot of cognitive decline, whereas the main issue is actually depression. This is, again, one of those instances where it's very hard to tell the difference between a cognitive disorder and a mood disorder.
And so digging a little deeper within the depression, as we know, along with depression many times comes suicidal ideation.
Yes.
And so what are the risks and differences in how suicide affects the elderly?
I'm going to check some statistics on this, so that's why I'm going to put my glasses on. There are actually 2 age peaks for suicide, and one of them is in late adolescence, early adulthood, when people are maybe very emotionally intense and more impulsive, and they don't yet have enough life experience to help them understand that the pain that they're in now is temporary, and they can gain control over their life. So that would be the younger age peak. But the other age peak for suicidality is actually older adults, and the risk actually increases as they age. The percentage gets higher and higher with each decade. And those are people who they're not impulsive necessarily, but they have kind of run out of, or feel like they have no more resources. They don't have enough of a happy future to consider. They may in fact have a terminal illness and choose to end their life. In fact, it's estimated that, let's say I think it's about 18% of older adults tend to commit suicide, but it's been estimated that may be underreported by almost 40%, because there's accidental overdoses. There are people who also choose to stop taking care of themselves. That's a way of self-destructing. So, and again, so the way it might look different is that it's more of a despair that is possibly a little bit more realistic, and certainly less impulsive than the younger age group of suicide.
Well, sure. I mean, if you lose connection with people, your friends are passed on.
Right.
And finances are short.
Exactly.
I mean, it just comes from other, and just like we've been talking about having someone there to advocate for you or to monitor what's going on with you, that happens less, and so it's almost like you become invisible.
Yes. I'm coming increasingly invisible as an older adult. Can't tell you how many people cut in front of you. So this constant assault of potentially of losses and of microaggressions does wear people down. The person who, if there's a demographic characteristic of the older adult that's most likely to commit suicide, it is the older single white male. They have lost usually a spouse either through death or divorce. They have lost status because they're old. They're not in the workforce anymore. Being in a marriage, even if it's not a great marriage. Being in a marriage is actually a protective factor, usually against suicide, although sometimes there's a suicide pact in which the couple will both decide to leave, usually due to one of them having a chronic illness or a deteriorating condition, such as a dementia. Some of the huge warning signs, though, if you're a family member or a friend, I'm going to have to put my glasses on. This is a condition called presbyopia, which is old eyes. They tend to lose interest. This is true for almost all suicidal risk assessment. They will lose interest in things that they usually find enjoyable. They begin to cut back on grooming, self-care, and social interaction. They may start not taking care of themselves medically. They decide, I'm not going to take my medication anymore because I'm dying anyway. There may be a trigger of a significant loss. It's a very dangerous time period. The person is feeling hopeless, worthless. The future is very dark. A very big red flag is they're beginning to put things in order. They're beginning to give the things away, make sure their will is taken care of. And it's not in a pragmatic kind of way. It's sort of in this hopeless, dark kind of mood. They're stockpiling medications, very bad sign. Preoccupation with death and or lack of concern about their own safety. Remarks like to the doctor, this is my last visit, or this is the last time you'll see me, bye honey. Those are obviously, you want to come back and check on those. And of course, if they express suicidal intent, take it very seriously.
Wow, okay, so there is a lot to consider there. And I hate to leave it on that note, but we're going to
This was the psychopathology issue.
we're going to finish this segment of the psychology of aging. I'm going to transition now into a couple of fun questions again, and ask you, Dr. Scaglione, what is your favorite movie
Ooh.
and why?
I'm an avid moviegoer. In fact, if I could see a movie every night, I would. So it's hard to say if I have a favorite. I'll see almost anything. Ones that come to mind tend to be ones that have to do with identity. So actually, God, what's it called? So here's a word finding issue, normal aging issue. Maybe you can help me with it. Harrison Ford is in it. It's futuristic. Robots are becoming self-aware. Blade Runner. It's one of my favorite movies. And then sometimes there's big sweeping romances. Dr. Zhivago is one of my favorites, but that's also sad.
And so along those lines, who's your favorite actor
Oh,
or actress?
Meryl Streep can do anything. So we'll stay there.
And then in terms of genre,
Oh, genre, sci-fi.
sci-fi?
Yeah, is often really badly acted, nonetheless really entertaining.
Okay, thank you so much for indulging us. And this concludes another episode of Muslims and Mental Health. As always, we appreciate your comments, feedback, and concerns, and you can reach us at nafshealertherapy@gmail.com. That's NAFSHEALER therapy@gmail.com. Thank you, and please join us again.